Hello everyone. A very good morning to all of you. I hope I am clearly visible and audible to you people. Uh, Let me confirm. I will start the class ahead. Give me a minute to confirm it. You can give me a thumbs up in the chat box if I am clearly visible and audible. I hope it is working. So I welcome you all for today's session. I am Dr. Priyanka Sachdev here, educator on an academy, and today I am here to take a very important topic from pathology as well as from medicine in an integrated manner, that is glomerulonephritis. Now students usually are afraid of this topic and many students request me, ma'am, to simplify this topic. So here I am to take the various types of glomerulonephritis for you. Now, glomerulonephritis, we classify glomerulonephritis into three categories. What are the three categories of glomerulonephritis? Okay, let me tell you. Glomerulonephritis is a disease in which glomerulus is inflamed. That is, inflammation of the glomerulus is known as glomerulonephritis. Right? Now, glomerulonephritis are of three types. What are the three types of glomerulonephritis? They are primary, they are secondary, and they are hereditary. Now you can understand the difference between them. Primary is a actually disease of the kidney which is involving the glomerulus. You know, glomerulus is a part of the nephron. In each kidney, humans have 1 million nephron. Nephron is the structural and functional unit of the kidney. Nephron have five portions, that is glomerulus and Bowman's capsule, proximal convoluted tubule PCT, loop of Henle, DCT and collecting duct. These are the five portions of the nephron. So when glomerulus is inflamed or involved or injured, the disease is known as glomerulonephritis. Right? Now, glomerulonephritis are of three types in primary. Actually, it is a disease of glomerulus. So these are of nine types. These are of nine types. Let me enumerate. It is acute proliferative glomerulonephritis, also known as post-streptococcal glomerulonephritis, number one. Number two, after acute proliferative, it is rapidly progressive glomerulonephritis. After that, it is minimal change disease which occurs in children. It is a glomerulonephritis of children. After that, there is membranous and membranoproliferative glomerulonephritis. Membranous glomerulonephritis and membranoproliferative glomerulonephritis. After that, there is focal segmental glomerulonephritis and focal segmental glomerulosclerosis. After that, there is IgA nephropathy, that is Berger's disease. And last but not least, it is chronic glomerulonephritis. You can count it out. These are nine primary glomerulonephritis. Coming on secondary. In secondary, actually, the disease is something else. Like the disease is diabetes, disease is SLE, right? But here the kidney and the glomerulus inside the kidney, inside the nephron is involved secondarily. So here there are many type of secondary, but I am going to teach you only the important one. Two I will teach you, that is diabetic nephropathy. The first I will teach you, and lupus nephropathy. Lupus nephropathy means the glomerulonephritis in SLE and the glomerulonephritis and diabetes. So diabetic nephropathy and lupus nephropathy I will teach you here. There are many, but I will teach you only two. That is secondary glomerulonephritis. Now coming on hereditary glomerulonephritis. As the name indicate, you can see hereditary means it will be congenital. So as the newborn child will be there. So on birth only the child will have this glomerulonephritis along with other in a syndrome along with the other features also. So there are four type of hereditary glomerulonephritis. The most important among these is Alport, which is the most common among hereditary. Alport syndrome. In Alport syndrome, it is a syndrome. Many things occur, but glomerulonephritis is one of them. So Alport syndrome is one of them. Nail patella is second. Fabry disease is third, and fourth is thin membrane disease. So these are the four type. These are the four type of hereditary glomerulonephritis. So I am going to teach you all these in a comparative manner. So it is going to be a super excited lecture for you. Right. So let me start with the primary. Let me start with the primary without wasting time. If you have understood the classification, let me start with primary glomerulonephritis. As I have told you, the primary glomerulonephritis are of nine types. You can see the nine names are in front of you, right? I advise you to make a comparative table between them. So here I have drawn a comparative table between the nine type of glomerulonephritis, primary glomerulonephritis. I will take one by one and explain you all of them, right? You can see the various names. It is acute proliferative glomerulonephritis, rapidly progressive glomerulonephritis, minimal change glomerulonephritis, membranous glomerulonephritis, membranoproliferative glomerulonephritis, focal segmental glomerulonephritis, glomerulosclerosis, IgA nephropathy, and chronic. In this sequence only, I am going to teach you. In each of them, I'm going to teach you etiology. Now, those who have attended my last lecture yesterday, they already know the various types of etiology which leads to glomerulonephritis. Basically, glomerulonephritis can occur due to three types of injury to the glomerulus. Whenever there will be injury to the glomerulus of the nephron, that will lead to glomerulonephritis. Now the point is that who is causing the injury? Is the injury is caused by antibodies? Is the injury is caused by cell? By cell I mean cytotoxic T cell. Or the injury is caused by complement, that is alternate pathway. So antibody mediated, immune complex mediated, or cell mediated, or it is alternate pathway. In alternate pathway it is complement mediated. So if it is antibody mediated, antigen antibody complexes are formed where? Either they are formed in circulation or they are formed in C2. If they are formed in C2 inside the kidney, in the glomerulus, what is the antigen? Is the antigen is fixed one or is the antigen is planted one? So those who have attended my yesterday's lecture, they already know that what I am talking about. So if you have missed that, please watch the recording. So you will have a better understanding of this column of the etiology of various types of glomerulonephritis. I will teach you one by one. In each of them, I will explain you the etiology. Let me come on gross, then I will teach you gross. After gross, there is microscopy. Now, there are three types of microscopes which are used for seeing glomerulonephritis. Light microscope, electron microscope, and immunofluorescence microscope. What do you mean by that? I mean, why we are using three different type of microscopes here to see any type of glomerulonephritis. In light microscope, we will see HNE feature of the slide. So that how glomerulus is looking morphologically after having glomerulonephritis, we will describe that. In electron microscopy and in immunofluorescence, we do not see glomerulus. We see the deposits inside the glomerular membrane, deposits inside the filtration barrier. So what do you mean by deposits? By deposits, I mean antigen antibody complexes. So whenever antigen antibody complexes are formed, that is the first type of injury, antibody mediated. So where they are deposited? There are four locations they can be deposited. So always in the center, there is basement membrane of the glomerulus. Always. On one side of the basement membrane, there is endothelial lining of the blood capillary. This is endothelial lining. On other side of the basement membrane, it is epithelial lining. It is visceral epithelial lining of the Bowman's capsule, right? Epithelium. So on one side, you can say it is, just a second. On one side, it is endothelial lining. On one side, it is epithelial lining. This epithelial lining is of Bowman's capsule. It is visceral epithelial, right? And the shape you can see, the green color, the shape is like the foot of a human. You know the foot of a human. The shape is like the foot. That's why it is known as podocytes. Podocytes. So epithelium is known as podocyte, and in the center we have basement membrane. This triad, this assembly is known as filtration barrier of the glomerulus. Filtration barrier. It is known as filtration barrier. Apart from it, there are many mesangial cells, which are the surrounding cells surrounding it, supporting cells surrounding it. So these are known as mesangial cells. Now the point arises that where the deposits are getting deposited, there can be four locations. Either the deposits will be inside the basement membrane here. You can see the deposits are in the basement membrane here. So these are known as intramembranous deposit, intramembranous, or the deposits at the junction of the basement membrane and the endothelium. See, I'm drawing it here. The deposits are at the junction of the basement membrane and the endothelium. These are known as subendothelial deposits, or the deposits are at the junction of basement membrane and epithelium. The deposits are at the junction of basement membrane and epithelium. These are known as subepithelial deposits. Apart from it, the deposits can be in the mesangium, the supporting mesangium. So these are known as mesangial deposits. So basically there are four locations of the deposits. They are in front of you. What are they? Intramembranous, subendothelial, subepithelial, or mesangial. This all is taking place inside the basement membrane, the filtration membrane of the glomerulus. So in light microscopy, they are invisible. They are visible in electron microscopy and immunofluorescence. Now, what is the difference between these two? In electron microscopy, you will be able to find out the location of deposit. So there are four locations. So which one is there in that particular type of glomerulonephritis? Whether the location is intramembranous, or it is subendothelial, or it is subepithelial, or it is mesangial. So what is the actual location of the deposit? It is shown by electron microscopy. And what is the composition of the deposit? So of course the deposit is a complex. So it will have a antigen antibody complex, and along with it there is a complement. So name the antibody. There are 5 type of antibodies, na? IgG, IgA, IgM, IgD, IgD, Gamma. So which antibody is present, and name the complement. There are 9 complements, C1 to C9. So which complement is present? So composition is known to us by immunofluorescence. So that is the relevance of 3 type of microscopy. It is in front of you. You should always know the basics. If you know the basics, it will be very easy for you to understand all type of glomerulonephritis in one go, in single go, right? So in light microscopy, you will see the HNE feature of the glomerulus. In electron microscopy, you will come to know the location of the deposits, and in immunofluorescence you will come to know the composition of the deposits. Okay, without wasting time, if you got, now add one more column here. I'm sorry. After that, add one more column, the last column. In the last column, write down the clinical feature. So in each type of glomerulonephritis, I am going to tell you whether this glomerulonephritis leads to nephritic syndrome or nephrotic syndrome. Those who have attended my yesterday's lecture, they already know the differences between the two syndromes. So some glomerulonephritis leads to nephritic syndrome, some glomerulonephritis leads to nephrotic syndrome, and accordingly their clinical features vary. You already know the clinical features inside them. Okay, and that's it. So let me start with the first one. I'm going to teach you 9 glomerulonephritis one by one. Let me start with the first one, APGN. I request all the students to please fill this column, that is APGN or PSGN column, with me. So let me start with the first glomerulonephritis out of 9, that is acute glomerulonephritis. There are 2 names given to this glomerulonephritis. What are the 2 names given to this? It is known as APGN and PSGN. What do you mean by APGN? Acute proliferative glomerulonephritis or post-streptococcal glomerulonephritis. You will understand the meaning of these names, why we are calling it. Let me finish it. Let me tell you the etiopathogenesis, then you will understand the meaning of it. Okay, coming on etiopathogenesis, we have done the introduction. Write down 2 names, APGN and PSGN, one and the same thing. Write down the etiology, write down the etiopathogenesis. So let me draw the etiopathogenesis. Imagine a human being. You can see this is a human being. These are the tonsil or pharynx of the human being. This human being is having tonsillitis or pharyngitis by a bacteria or skin infection by the bacteria. What is the name of this bacteria? The name of the bacteria is group A beta streptococcus bacteria. It is known as gas bacteria. So group A beta streptococcus bacteria is causing either skin infection or pharyngitis in this person. Okay, now this is the blood vessel of this person. So bacteria is going in the blood. After the causing the tonsillitis, pharyngitis or skin infection, the bacteria is moving to the blood. From the blood, the bacteria is going to the kidney. So let me draw a kidney. So these are the kidneys. So bacteria is moving to the kidney. So bacteria entered kidney from blood. Entered kidney from blood. Now inside the kidney, we have nephron. In each kidney, there is 1 million of nephron. Inside the nephron, we have filtration barrier. So let me draw a filtration barrier. In filtration barrier inside this kidney, inside the filtration barrier, at the center, we have basement membrane. On one side, there is endothelium, and on other side there is visceral podocytes, that is epithelium, right? So this is the filtration barrier. So this bacteria, after causing pharyngitis, tonsillitis or skin infection, it is coming in the blood. From the blood it is entering in the kidney. In the kidney it is going to this filtration barrier. In the filtration barrier, the bacteria is deposited on podocyte. The bacteria is deposited on podocyte. Now this bacteria is planted on the filtration barrier. That's why it is known as planted antigen. This bacteria, now it is known as planted antigen. It is already planted on the filtration barrier. Now what will happen? Body will form antibodies against the bacteria. Let me draw. The body will form antibodies against this bacteria. So antibodies are formed in the blood. So they will also move in the kidney behind the bacteria. वो भी पीछे पीछे जाएगी bacteria के. So antibody will also move in the kidney. Inside the kidney, antibody will also move to the filtration barrier, and antibody will form a bond here, right, with the antigen. So antigen antibody complexes are formed, but they are not formed in the blood. They are not formed in the blood. Antigen antibody complexes are not forming in the blood. They are forming in kidney. This is known as in situ complex formation. So complex formation, antigen antibody complex formation takes place in situ inside, because first bacteria is coming and behind it antibody is coming. Antigen antibody complexes are not coming from the blood. First bacteria coming, getting planted there, and then antibody is coming behind it. So in situ antigen antibody complex takes place, formation takes place against a planted antigen, right? So here it will cause damage because of this antigen antibody complex. There is a damage in this filtration barrier and it will lead to glomerulonephritis. That's why this glomerulonephritis is known as post-streptococcal glomerulonephritis, because it is occurring after a bacterial infection. The name of the bacteria is group A beta streptococcus. That's why it is known as PSGN. And the second thing here, it is known as acute because it is very rapid. Acute proliferative. I will tell you the meaning of proliferative glomerulonephritis. These are the two names given to it. Here the glomerulus is damaged and it will lead to glomerulonephritis. Now, tell me deposits. Where the deposits are formed here? Where the deposits are formed? I have told you 4 locations of the deposits. By deposits, I mean complexes, antigen antibody complexes. Look at the diagram, the barrier. So either the complexes are formed intramembranous, or they are formed subendothelial, or they are formed subepithelial, or they are formed mesangial. Where they are formed, you yourself tell me where they are formed. You can see the antigen antibody complexes are formed on the podocytes, on the epithelium. So my answer is subepithelial. So subepithelial deposits are formed and they will cause damage. Have you got it? So this is the etiopathogenesis. You have to write like this. So there is a bacteria. The name of the bacteria is group A beta streptococcus bacteria, known as gas bacteria. It will come in the human being and cause pharyngitis or skin infection in that human being, right? Now the bacteria will come in the blood. From the blood, it will go to the kidney. In the kidney, it will go to the filtration barrier. In the filtration barrier, it will get deposited on the visceral podocytes, that is epithelium. Now this bacteria is known as planted antigen. Now body will form antibodies against it. Antibodies are formed in the blood. They will also go behind the bacteria inside the kidney. Inside the kidney, they will bind with the antigen, the planted antigen, and they will form complexes with it. So antigen antibody complexes are not formed in blood. They are formed inside the kidney, that is in situ formation, in situ antigen antibody complex formation against a planted antigen. Now these complexes are formed and along with it a complement will also come. So deposits are subepithelial. Subepithelial. Give me a thumbs up if you got it. You can see the same diagram from the Robbins which I have drawn for you. Beautiful diagram. Can you see in the center, this is the basement membrane, the pink one. I'm drawing the margin with blue color. The pink one is the basement membrane. Can you appreciate the basement membrane? Of course, you all can see the basement membrane. On one side of the basement membrane, you can appreciate this is the endothelial cell. These are the endothelial cells, the flattened one. These are multiple endothelial cells, right? On other side of the basement membrane, you can appreciate these are the podocytes. These are the visceral epithelial or podocytes. On the podocytes, please appreciate the red dots. Can you appreciate the red color dots? That is the planted antigen, that is the bacteria. So bacteria is planted. It is a planted bacteria, planted antigen on the podocyte. Now look at the lumen of the capillary. In the lumen of the capillary, can you appreciate multiple? Can you appreciate these? Antibodies are formed, multiple antibodies. So antibodies are also coming and forming bonds here. So antigen antibody complexes are formed and it will destroy the barrier. That will lead to glomerulonephritis. And complexes are formed, that is deposits are formed subepithelial. Subepithelial deposits are formed, right? But these deposits which are formed subepithelial, they are large, they are big. Can you see? Big deposits are there. So that's why these deposits are known as lumpy, dumpy, bumpy deposits. Lumpy, bumpy, dumpy, humpy, because they are big in size. Have you got it? Okay. So let me come on the gross. The next heading is the gross. If you see the kidney from outside, it is all happening inside the kidney. So inside this kidney, we have nephron. This is the nephron. We have 1 million nephron in each kidney. In this nephron, this is the glomerulus. It is afferent arteriole forming tuft of capillary and forming efferent arteriole. So this all scenario which I have told you, it is taking place here inside the filtration barrier. So because of this antigen antibody complexes formation, the entire kidney have multiple red colored dots on it. Can you see? The entire kidney have multiple red colored dots on it. So it is looking, there is an insect known as flea. So flea, there is an insect known as flea. Flea bitten kidney. Flea have bitten the kidney at multiple sites, right? That's why the kidney is having multiple red spots. So there is a terminology known as flea bitten kidney. So in gross, learn the terminology flea bitten kidney. What do you mean by that? There are multiple petechial hemorrhages on the surface of the kidney externally. Actually, these hemorrhages are due to antigen antibody complexes formation inside the kidney. So that is known as flea bitten kidney. Now the three type of microscopy, one by one I will tell you. So the first microscopy is light microscopy. This is the diagram of light microscopy. So this is a glomerulus. Can you appreciate a glomerulus? In the glomerulus there is a filtration barrier, right? Can you appreciate this is the endothelium, this is the capillary. Please appreciate the capillaries, multiple capillaries. Let me draw few of them. So these are the capillaries. Now please see the lining of the capillaries. You will be you will be able to appreciate the thin flattened endothelium inside it. Can you appreciate the thin flattened endothelium inside it? Yes, you can appreciate. So this is the thin flattened endothelial cells inside the capillary. So these all are illuminated capillaries having thin flattened endothelium inside it. Say yes or no. Say yes or no. So thin flattened endothelium inside it is present, right? And the red color line is the basement membrane. So basement membrane, on one side there is endothelium, on other side it is epithelium. Where is the epithelium? Epithelium is visceral podocyte. So this is the epithelium. I'm drawing the green line. Can you see the flattened cells inside it? The flattened cells, I'm not drawing everywhere, but yeah, there is a flattened cells around it. So you will say, ma'am, what are the cells between them? What is this cluster? Let me draw the cells I'm talking. So this cells I'm talking about. What are all these cells? So there is basement membrane. On one side there is endothelium. On one side there is epithelium. But in between the endothelium and epithelium, there are multiple WBCs. Most of them, if you zoom it out, you will find these are neutrophils because they are multilobated, and few of them are lymphocytes. So the glomerulus is inflamed by WBC. So whenever, actually what is happening, okay, let me tell you in detail for those who want to understand the detail. So there is a basement membrane at the center, actually, right? On one side there is endothelium, on one side there is endothelium, on other side there is visceral podocyte or epithelium. This is happening. Now antigen is coming and getting planted on the podocyte, right? This is antigen. Behind it, body is forming antibodies. So antibodies are also coming and forming a bond with the antigen. So antigen antibody complexes are formed here. But these antigen antibody complexes are not visible on light microscopy. If you see on light microscopy, these complexes are not visible. So because of these complements from the lumen of the blood, this is capillary now, this is capillary. So inside it, blood is present. In the lumen of the blood, there are WBCs. Multiple WBCs will come from the blood here. So multiple WBCs will come from the blood and get deposited there. Get deposited here. Multiple WBCs. It can be neutrophil and lymphocyte. So on light microscopy, we are unable to see these antigen antibody complexes. We are able to see these WBCs. So this is the diagram. This is the diagram. Can you see multiple WBCs? So because of the entry of multiple WBCs inside the glomerulus, see the size of the glomerulus. The glomerulus is enlarged in size, number one. It is hypercellular, number two, or it is proliferative. The meaning of proliferative, now you will understand, it's proliferative means cellularity. So it is hypercellular, proliferative, enlarged glomerulus, and cellularity is because of leukocytes, mainly neutrophils and lymphocytes. That's it. So now compare it. Can you see the two diagrams back to back? You can see. Yes, you can see. So can you see this is a normal glomerulus? Yes. And can you see this is the glomerulus of PSGN? Now compare it. Compare it. What you will see? What you are seeing here? You will say that the glomerulus here, it is enlarged. Number one, it is enlarged in PSGN. Number two, it is hypercellular. Compare with normal. It is proliferative. And if you zoom out, most of these cells are going to be WBCs. WBCs. Give me a thumbs up. So that's it. That's it. You have to write the glomerulus is enlarged. It is hypercellular. It is proliferative and multiple WBCs are coming. That's it. So that is light microscopy. Coming on electron microscopy. On electron microscopy, you will see the location of deposits. So what was the location? It was subepithelial. There are four options in location. What are the four options? Intramembranous, subendothelial, subepithelial, and mesangial. Out of the four here, the deposits are subepithelial. You already know it. But the size of the deposit is big. That's why it is known as lumpy, bumpy. It is known as lumpy, bumpy, humpy deposits, right? In this diagram, can you see? Should I draw the basement membrane? Okay. Can you see this light pink color, which I am marking with blue? The light pink color is the basement membrane. Okay. On this basement membrane, you can see on inner side, the green color cells are the endothelial cells. Can you see these green color cells? These are the endothelial cells on inner side of the basement membrane, right? On outer side, can you see the blue color cells? The blue color cells I'm marking with blue. See, these are visceral podocytes. See the shape. These are podocytes, right? These are the podocyte shapes. Give me a thumbs up. Now, can you see the dark pink color? Can you see this dark pink color deposits? Please appreciate. Please everyone appreciate this dark pink color I'm marking with yellow. These are the deposits. They are present on epithelium. That is visceral podocytes. That is subepithelial deposits are there, right? Now see, they are big, big, like the hump of a camel. Like the hump of a camel. So these are known as lumpy, bumpy, humpy deposits. Humpy deposits. You got my point? So subepithelial, lumpy, bumpy, humpy deposits are seen on electron microscopy. This is the actual image. Appreciate the deposit. It can come in the form of image-based question in your exam, right? It is a lumpy, bumpy, humpy subepithelial deposit, right? See the size, appreciate the size. Should I go ahead? The next is immunofluorescence microscopy. The third and the last is immunofluorescence microscopy. Here we will come to know the composition of deposit. In all deposit, there is an antigen. The antigen is the bacteria. So I'm not concerned with the bacteria. Along with antigen, there is an antibody. Which antibody it is? And when antigen antibody complex is formed, always there is a complement. There is a triad: antigen, antibody, and complement. So name the antibody. There are 5 type of antibodies, na? IgG, IgM, IgD, IgE. It is IgG. It is IgE. And name the complement. There are 9 complements now, C1 to C9. So it is always C3. So it is IgG and C3 along with the antigen. So the composition is IgG and C3. Please learn it. So it will look like this. This is immunofluorescence. Immunofluorescence. Here you will come to know the composition of the deposit. Now see, this is the summary. In this summary, what you can see, the 3 microscopies. This is light microscopic picture. This is electron microscopic picture. And this is immunofluorescence microscopic picture. Now tell me the summary. In light microscopy, you can see a glomerulus, which is enlarged, which is hypercellular, which is proliferative and infiltrated by WBCs or leukocyte, that is neutrophil and lymphocyte. In electron microscopy, the deposits, the dark pink color deposits you can see. Can you see the dark pink color deposits? So the location of the deposit is subepithelial and they are lumpy, bumpy, humpy deposits. That's it. In immunofluorescence, you can see the composition here. The composition is IgG plus C3, right? By taking various antibodies, we will come to know this composition. So that is the summary. That is the summary. Last thing is clinical feature. I have told you there are 2 type of syndromes, nephritic and nephrotic. You already know the difference. PSGN or APGN, that is post-streptococcal or acute proliferative glomerulonephritis, leads to nephritic syndrome, not nephrotic. What are the clinical features of nephritic? Those who have attended my yesterday's lecture, they know the 5 features of nephritic syndrome. Number 1 is hematuria, patient will have blood in urine. Number 2, proteinuria, patient will have protein in urine. Number 3, hypertension, patient will have increased blood pressure. Patient will have oliguria and patient will have edema. So you know the 5 features of nephritic syndrome. Patient is coming to you with all these 5 features and it occurs in adults. I am done. I am done with the first type of glomerulonephritis. Everyone give me a thumbs up if you got my point. Everyone give me a thumbs up. APGN. What do you mean by APGN? Acute. Now let me fill this table for you. Please everyone fill this table with me so that we will have a comparison between all type of glomerulonephritis. Acute proliferative glomerulonephritis, also known as post-streptococcal glomerulonephritis, APGN or PSGN. What is the etiology? Who will tell me the etiology? What is the etiology here? Here antigen antibody complexes are formed in C2. In C2 against a planted antigen. Planted antigen is the bacteria. The name of the bacteria is gas bacteria. So that gas bacteria is coming from the pharynx or skin infection into the blood. From the blood it is coming in the kidney. From kidney it is coming on the podocyte and getting planted there. So antibodies are formed against it and antigen antibody complexes are formed in C2 against the planted antigen. That's it. That is the etiology. What is the gross? Who will tell me the gross? What is the gross? In gross, learn one word. Flea bitten kidney. What do you mean by flea bitten kidney? Multiple petechial hemorrhages on the surfaces of the kidney, right? On light now the 3 microscopy. On light microscopy, the glomerulus is enlarged. It is hypercellular. It is proliferative and infiltrated by WBCs, leukocyte, that is neutrophil and lymphocyte. On electron microscopy, what is the location of deposit? The location of the deposit is subepithelial and deposits are big in size. They are lumpy, bumpy, humpy deposits. And location is subepithelial. In immunofluorescence, you will come to know the composition. The composition is IgG plus C3 along with the antigen, right? After that, you have one more column. The name of the one more column here, I asked you to write the clinical features. In clinical features, write down clearly it is nephritic syndrome, not nephrotic. And you know the 5 clinical features of nephritic syndrome, that is hematuria, blood in urine, proteinuria, protein in urine, hypertension, oliguria and edema. That's it. Have you got it? Have you got it? I really tried hard in explaining you the 5 types, the various types of glomerulonephritis. This is the first one. I'm going to teach you all 9 types in this way. So everyone give me a thumbs up if you got this point. Everyone. Let me see if I can see a chat. Just a second. Yeah. So that's it. That's it. So we have completed the first type of glomerulonephritis. Let me come on the second type of glomerulonephritis, that is RPGN, rapidly progressive glomerulonephritis, right? So before that, there are few polls, there are few MCQs based on. So I will teach you all type of glomerulonephritis, 9 type one by one. But after every glomerulonephritis, I will tell you the MCQs, that is based on that particular glomerulonephritis, which already asked in your previous year question papers. So in the form of the polls, I will ask if anyone knows the answer, please write your answer in the chat box, in the comment box, right? This is the first question in front of you. This is the first question in front of you. Let me read the question. All are true about PSGN, post-streptococcal glomerulonephritis, except. Now please mind the word except in the question. Please read what are the 4 options. Crescent formation, subepithelial deposit, granular deposit made up of IgG, or deposits are made up of IgA. Which is wrong among them? Which is wrong among them? The examiner is asking which is wrong. So answer is but obvious. If anyone knows the answer, please write your answer in the comment box. What is wrong? Yes, this statement is wrong. D is wrong among them because deposits are made up of IgG. Deposits are never made up of IgA. You will say, ma'am, what about crescent formation? You have not taught us about the crescent formation. I will come on that point. Sometimes, rarely, crescent formation takes place in PSGN. But I'm not saying very frequently, but yeah, it is taking place. Subepithelial deposits always takes place. We know, we have seen the location of the deposits in electron microscopy. And in immunofluorescence, we have seen the composition. In the composition, it is IgG, not IgA. So incorrect among them is D. And because except is asked, my answer is D. That's why my answer is D. I hope you got it. Okay. Coming on the next question. This is the next question in front of you. Let me read the question. What is the pathogenesis of acute proliferative glomerulonephritis? APGN. You should know the short forms of these. Acute proliferative glomerulonephritis. Yes. What is the pathogenesis? Why it is happening? What is etiopathogenesis? Is it cytotoxic T cell mediation which is causing the injury? Is it immune complex which is causing the injury? Is it antibody which is causing the injury? Or is it cell mediated which is causing the injury? Yes, yes, of course. Here it is the antigen antibody complexes which are formed in situ against a planted antigen, antigen which is causing the injury. So the correct answer here is B. B. If B is not given in the option, I will go with C, but best to go with B. So correct answer here is B. Coming to the next question, there are many questions on this concept. You can see here. The next question is very easy right now. Subepithelial humpy deposits are seen in which glomerulonephritis? The 4 options are in front of you. Is it seen in minimal change glomerulonephritis, membranous glomerulonephritis, membranoproliferative glomerulonephritis, or PSGN, post-streptococcal glomerulonephritis? Currently, the question is very easy for all of you because I taught you only one type of glomerulonephritis in which the subepithelial deposits are there. So everyone knows the answer. It is PSGN. So but if I launch the same poll after teaching you all 9 type of glomerulonephritis, the same question will become difficult for you. You will get confused. Okay, what about others? So what is the location of deposit in other glomerulonephritis? Of course, it is not subepithelial. In the remaining 3, either it is subendothelial or intramembranous or mesangial, but it is not subepithelial. So subepithelial seen in PSGN, right? Among these it is seen in PSGN. So correct answer here is D. You already know the answer. Okay. This is the next question in front of you. PSGN leads to what? Is it leads to dense deposit disease, or is it leading to RPGN? Is it leading to nephrotic syndrome? Is it leading to nephritic syndrome? I have told you in clinical features very clearly that PSGN leads to nephritic syndrome. Yes. So there are 5 features of nephritic syndrome. hematuria, proteinuria, hypertension, edema, and oliguria. The patient will present with 5 complaints, 5 symptoms, 5 clinical features. Right, so that is nephritic, not nephrotic, not RPGN, not dense. So correct answer here is D. Right, correct answer here is D. So that is how many questions will come in your exam based on this topic. You can see many questions are coming based on this topic. Okay. Okay, so I will start the next type of glomerulonephritis, that is RPGN, rapidly progressive glomerulonephritis, and I request all of you to fill the table with me. Give me a thumbs up in the chat box. Give me a thumbs up if you got my point. So in this way, we are going to cover all 9 glomerulonephritis one by one. But this link is expiring. So give me a break of just 5 minutes. In 5 minutes, join another link. Join another link. I will start with RPGN in that link. So give me a break for 5 minutes. I'm ending this lecture. Wait for a while. Okay. So, okay, my next lecture is just after 5 minutes. Just after 5 minutes, join another link on this YouTube channel only. That is Future Doctors. You will be able to watch my next lecture after 5 minutes. That is, I think the label of that is RPGN only. So, join the lecture RPGN, in which I am going to teach you RPGN, right? Now for the newcomers who don't know about the paid subscription of Unacademy, on Unacademy we provide two type of paid subscription. These are the free classes. There are two type of paid subscription. One is Plus and one is Iconic. What is the difference between the two? If you purchase Plus subscription, we will provide you access to live and recorded lectures of Unacademy only, right? If you purchase Iconic subscription, along with Unacademy, we will provide access to the prep letter also. So if you are thinking of taking paid subscription, go with Iconic. That is my advice, because here along with the features of Plus, you are getting additional feature of preparator. What about the price difference between the two? A little bit price difference between the two, but better to go with Iconic. Rest is your choice. NEET PG notes are available on Unacademy, and you can order your copy, the hard copy of the notes. If you are taking a Plus subscription, 1 year, at least 1 year or more than 1 year, these notes copy is free to you. It is free of cost. So you can grab this opportunity. If you want the notes, take a subscription of 1 year, at least 1 year, and you will get the copy of this notes, right? Once you take the subscription, you will be eligible for all these batches in which the top educators from India will teach you in a integrated manner for all the competitive exams. NEET PG, FMG, INICT, university exams, everything. These are the various plans available with us. In Plus, these are the plans. In Iconic, these are the plans. The minimum plan is 3 months. The maximum plan is 4 year. You can notice one thing, longer the plan, cheaper it is. So if you are a first prof, second prof student, you can select a longer plan. It is more cost effective for you. The 4 year plan, 3 year plan, 2 year plan. But if you want to give a trial, you are an intern, you are a final year student, you can start with 3 months also. You can always have a choice of extension, right? So whatever plan you are choosing from Plus or Iconic, according to your wish, if before payment you apply my code, that is Sachdev 10, you will get 10%, minimum 10% discount. So please remember the code. It is Sachdev 10, SACHDEV, Sachdev 10 is the code. I request all of you to distribute this code on your batch groups and all the medicos throughout the world, so that everyone can use this code and apply this code and get the maximum discount. This code is useful in two ways. The code is Sachdev 10, as I have told you, SACHDEV, Sachdev 10. The one student who want to watch only free classes, who do not want to take subscription, so they can unlock any free class, not the paid one, free class by using this code. But the one who want to take paid subscription also, that is Plus or Iconic, if they apply my code, they will get maximum discount. So the code is useful to all students. So for watching all these classes on Academy, you have to install the Unacademy Learners app from the Play Store, and you can go with it. The details are given. Thank you very much for being with me, and I want everyone to be back after 5 minutes for the next lecture, the next glomerulonephritis, that is RPGN. Don't go anywhere. Have a cup of tea, coffee, refresh yourself and come back. I'm